We'll now turn to Dr. Amit, who will discuss the presentations and also moderate an open discussion on psychotherapy in borderline personality disorder in public mental health. Dr. Amit is a senior psychiatrist, the former deputy director of the Daycare Psychiatric Unit in Shalvata Mental Health Center, which is a CBT-oriented unit treating mainly borderline personality disorder patients. Currently, he is a senior psychiatrist at the Open Ward, which is actually more psychodynamically oriented open ward, right? His main areas of interest are psychodynamic psychotherapy and philosophical foundations of psychoanalytic theories. I would just say that while I see these patients in the psychiatric ER constantly repeating, Dr. Saad is actually on an everyday basis sees them and try to treat them either in hospitalizations or in an outpatient unit. And so for us, this is a very important discussion because we are constantly looking for answers to these patients. So, Dr. Saad.
Okay, so I'd like to thank you all for thanking the speakers for the panel. I think that leaving aside mentalization-based therapy, we've seen here most up-to-date approaches to borderline personality disorder. And all of these approaches provide both a theory about the pathology of borderline personality disorder and a therapeutic method. What I'd like to do now is to raise some questions from the perspective of a public health provider, and to wonder about the obstacles and opportunities to implement these methods in the public health services. In the place where I work, we usually encounter those most severe cases of borderline personality disorder, those who need hospitalization, who usually had at least one or even more psychotherapies in the past. And you can say that we treat those most severe cases among the 50% dropouts or those who failed the former psychotherapies in our studies. So though I'm quite thrilled about the proposed methods, I'd like to take the devil's advocate's position and to raise some skeptical questions. Now, I take this position not because I like being skeptic, though I do like being skeptic, but mainly because as someone who treats patients with borderline personality disorder, I find myself many times skeptical about my abilities as a therapist and about my powers to heal these patients and about the methods, the therapeutic method that I use. Now, I guess that one of the first things that strikes you when you read the evidence about these approaches is that you see the dodo effect. I mean, most of them gets pretty much the same outcomes. I mean, there are some minor differences. They are not always tested as primary outcome. I'd really like to take a look at the drop-off levels that Shkol presented here, which is not a minor outcome. I think it's quite important. See, I do believe that these approaches, DBT, TFP, DDP, and schema therapy work. So in light of this dodo effect, I'd like to ask you whether you think that there is some common factor which all of these approaches share. And if so, do you think, do you have any ideas what this common factor might be? If there is a common factor, then we might think that maybe we use just different formulations to describe the same phenomena. Professor Gregory discussed some several similarities between DDP and other approaches. Professor Fay did it as well. When I used to give DBT treatment, I noticed that many times when you talk about the second hierarchy that Ifat mentioned here, when you discuss those behaviors that interfere with adherence to the therapy, then most of the time you analyze the transference. So it sounds similar to the transference-focused psychotherapy, and also sounds similar to the alterity and maybe to the modes that you use in schema therapy. I don't know. So this is one option. Now, the other option is that there is no common factor, or there is more than the common factor, And then we might wonder whether the different approaches get similar results with the same patients. Or in other words, I wonder whether there are patients who benefit more from DBT and others who benefit more from TFP or DBT or stream therapy. And this is a very hot question for public health services because our options are limited. And I can give you an example. In my clinic in Shalvat, I can refer my patients to two types of group therapies for borderline personality disorder. One group is psychodynamic group, another is based on DBT approaches. And now I wonder who should I refer to where. And this is a question for you. And we can ask this question from a different direction. As said, our patient often having the best former psychotherapy. So we see, for instance, patient who failed in DBT and now they are hospitalized. So would you think that such a patient would be a good candidate for DBT or TFP or another approach? I mean, now if you think that there is a common factor, then providing another psychotherapy is just doing the same thing over and over again. It's like voting the same prime minister again and again and again. I don't know if it's useful. It's not, all right? And also we need to think about, if we think about Shabbat, we also got one method or two methods. Do we need to integrate more methods? It's very complicated to teach the staff to adhere to a certain method. We teach them all sorts of methods, and eventually they do what they know from the beginning. They end up with psychodynamic psychotherapy, which is great, but if you want to really implement a method, that's a process that takes several years. And now the question is whether we should implement more than one method. So this is the main question. I've got several other questions regarding the implementation of these approaches in public health services, but I think that it would be better to open the discussion for the audience or to let you answer these questions.
What I can speak to is, I think I'm not a big believer in the dodo effect, even though if you look at all the therapies and meta-analyses, you don't see much difference. But I think there are differences for different populations, and that research in borderline personality disorder has been very little looking at predictors of outcome. And I do think it's really the next big direction is, we do have these evidence-based treatments, and consistently, I've been surprised how much better they work compared to usual care in the community. And that's certainly true in the Syracuse area, where I'm from, where counseling it's not even called psychotherapy anymore, it's called counseling. When it's been studied what counseling in the US involves, it's mainly chatting. And I can tell you for this patient population, every time we look at it, whether it's a naturalistic or research study, we just look naturalistically, their outcomes are terrible. There's no improvement at all with usual care. So I think the main point I want to emphasize is that it's really helpful to have so many effective treatments, and then which treatment you choose, I think, is going to be now a big area of research. But we're so fortunate to have so many effective treatments, just like we are for effective antidepressants or antipsychotics. You don't just want one antidepressant. You need to have more than one, because not everyone's going to respond to that one antidepressant. So I think there's advantage in having a plurality of effective treatments.
Most of research shows before and after. So you see that something helped, but we don't know what and what was the mechanism. But what is, I'll take a Corotian way of putting it, what is close to experience near, is one thing that is very important in treating these vulnerable people, and I think that the more modern approaches do use a more humanistic approach, a more validating approach, and less authoritarian, less widescreen kind of naturalistic stance that was more prominent in the regular dynamic psychotherapy. So what I'm saying is that the therapeutic relationship is the most important thing, and if the therapist is also passionate about what he's doing, and the one very important thing, he knows what he is doing. So he has an agenda. He enters the room and he actually knows what he is going to do, which I think is not trivial at all. So he feels competent, and the patient feels more competent and more safe and more contained. And so I think that the fact that there is some systematic way is very important. What exactly includes, I think it's less important, but the fact is that DBT has so many RCTs. The problem is that you need to put a lot of effort to learn these methods, and also there are many resistances to each of them, but to DBT there are many resistances. It's not easy to teach it, and it's not easy to teach it, it's not easy to learn it, and it's not easy to implement it in the public services, which is another problem. But it will be more humble in our therapeutic stance, and will be more precise in our goal setting, and more systematic and competent in our handling the session. I think that will be very helpful.
Remembering hearing Peter Fonagy speak a couple of times when he visited Israel, where he would talk about mentalization-based therapy, and at various points people would raise their arm, raise their hands in the audience and say, we do this in DBT, we do this in chemotherapy, we do this in motion-focused therapy. And his pat response, he's always said this, I've seen this now in a few different visits, is great, do more of that. Which I think is a great answer. Like, there are wonderful ideas behind mentalization-based therapy, behind DBT, behind deconstructive therapy, certainly behind chemotherapy, because in chemotherapy they're all stolen. And so they're great ideas from all these other approaches. And I think one thing that I'm looking for in all these approaches, and I think exists already, is this idea of integration between various mindsets. And so the big integration is the one between looking at developmental, let's call them psychodynamic issues on the one hand, and the other side of it is the goal-oriented approach that was typified by CBT and DBT, but I think actually exists in all these approaches. There's going to be a structure, we know where we're going with this, it's not just vague, there's a sense of hope, and then we're trying to do these things together. And one thing that I think I wasn't as aware of until I heard the talks of my colleagues today is just how much each of these approaches also integrates beyond these ideas of development and dynamics, and the idea of structure from, let's call it the CBT side, also integrate the idea of attending to the relationship, such a central word, which I think is crucial in all these approaches, and attending to affect. I think that one last plug for chemotherapy, because I got to speak last, would be to say that I think it's in line with this revolution that's happening in psychotherapy in general these days, of bringing affect back in a very specific way, not just by looking at emotion regulation, but by looking at the activation of emotion, the deliberate activation of emotion, the attempt to try and work with hot emotion that is often there anyway in DBT. In borderline personality disorder, but that needs to be activated in certain ways so that we can get some memory reconsolidation or some deeper change that we can often get with more surface cognitive behavioral work. So that's my experience.
Thank you very much. First of all, we thank all the listeners of this panel and all the presenters, which I think gave us many ideas, I think, towards thinking and about how to implement different approaches of psychotherapy in the public mental health domain. Thank you very much. We are closing this panel. Have a great day.